The subcommittee hearing is reconvened, and we still have some opening statements, starting on our side with our chairman, Mr. Waxman from California.
Thank you, Chairman Pallone, for holding this important hearing, and I know we're anxious to hear from our witnesses, and I regret that we had the votes that interrupted our hearing. But we are looking today at the extraordinary benefits and examining the possible risks associated with the use of radiation in medicine. And let me be clear at the outset, diagnostic technologies like CAT scans that identify tumors and therapeutic procedures such as radioactive seeds to treat prostate cancer are potentially life-saving. They're important interventions in our medical toolbox, and our healthcare system is unquestionably much better because of them. But recent reports and studies have raised questions about the relative safety of these technologies. No medical intervention is 100% safe, and patients' individual tolerance for risks in being exposed to such procedures varies as well. These are dangers that generally cannot be avoided altogether. But the purpose of this hearing is to learn more about those risks and hazards from radiation that would appear to be preventable. And there have been recent examples, as reported in the press. Investigators at the NRC found that a cancer unit at the VA hospital in Philadelphia botched 92 out of 116 procedures using radioactive seeds to treat patients with prostate cancers. Over 200 patients were mistakenly exposed to up to 8 times the normal dose of radiation during brain scans at Cedars-Sinai Hospital in Los Angeles. Because of a computer error that went undetected, Scott Jerome Parks, the son of one of today's witnesses, was blasted with excess radiation on 3 consecutive days during his treatment for tongue cancer. Scott died from his radiation exposure at the age of 43. Despite these patients' need and consent for the life-saving technology used, the end result clearly is not what they signed up for. Alarmingly, as we will hear from a number of today's witnesses, these are not isolated cases. The mistakes made in these instances, while perhaps not widespread, we hope not widespread, appear to be more than just random and rare. They are occurring all across the country and in hospitals and physician offices alike. The reasons for this poor quality of care would seem to be multifaceted, whether it's a lack of standardization of equipment or lax and even non-existing state licensing requirements for machine operators or outdated federal oversight authority. Experts tell us that more can and should be done to reduce unnecessary radiation exposure and medical errors. Indeed, action has already been called for by the medical imaging manufacturers and some radiation provider groups whom we will hear from today. As we move forward, I would hope that we can all agree on 2 basic premises. First is the enormous medical value of our various radiologic techniques. As I mentioned earlier, we want to underscore the point again, both diagnostic and therapeutic radiology interventions save lives. We want them, we need them. Second is the obligation to ensure that these interventions are as safe as they can be and that everything is being done to make that a reality. Patients are entitled to nothing less. With these principles in mind, I believe our job today is simple and straightforward: to understand how to lower the risks associated with radiation in medicine to make it as safe as possible without reducing its many benefits to patients and researchers. We have an outstanding group of witnesses no longer this morning, this afternoon. They're here to help us learn more about these issues. I thank each of them in advance for their testimony, and I look forward to hearing from them, but in my case, from reading their testimony, because I'm compelled to go to a meeting with the Speaker on health care, which will require me to miss the testimony, but we'll have a chance to review it, and I thank the witnesses for being here.
Thank you, Chairman Waxman. The gentlewoman from North Carolina, Ms. Myrick.
Thank you, Mr. Chairman. For the sake of time, I'm going to submit my statement for the record along with a letter from the Society for Radiation Oncology Administrators.
Without objection, so ordered.
Thank you.
Thank you. And so I think we've had opening statements from everyone else, so we'll move to our panel. And let me introduce each of the panelists, if I could, beginning on my left, is Mr. James and Mrs. Donna Parks from Gulfport, Mississippi. Thank you for being with us today. And Suzanne Lindley from Canton, Texas. And then we have Dr. Rebecca Smith-Binman, who's professor in residence of radiology and epidemiology and biostatistics, obstetrics, gynecology, and reproductive medicine. I didn't realize we had all those at the University of California at San Francisco. And then we have Dr. Eric Klein, who's professor of radiation oncology at Washington University in St. Louis. And then we have Dr. Cynthia H. McCullough, who is director of CT Clinical Innovation of the CT Clinical Innovation Center, Department of Radiology at the Mayo Clinic, and professor of radiological physics at the College of Medicine at the Mayo Clinic. That's our panel. We ask you to give us 5-minute opening statements. If you can limit it to that, please, and your statements, your full statements become part of the record. Then we'll have questions from the panel. I should mention that beyond this, you may get additional written questions from the panel within the next 10 days or so as well. We'll start with you, Mr. Parks. Thank you for being here. Let's make sure that your microphone is on. It should be the green light. And maybe bring that a little closer to you, Mr. Parks, so that we can...
Mr. Chairman and committee members, we want to thank you for the opportunity of coming here to talk. We are here to testify on behalf of our son Scott, who died from an extreme overdose of radiation by a very inept team of therapists using a linear accelerator. It is a horrible way to die. What was to be a minimally invasive procedure turned out to be a 2-year nightmare for the whole family, especially he and his wife. They were in New York City, and that's where most of this occurred. We were with Scott and Carmen when Scott's feeding tube was implanted. At that time, we had been convinced that we were doing the right thing. He had not wanted a surgical procedure, which would have been very bad. My hearing aid just went out. So he chose what he called the laser treatment, and we thought it would be very quick. After the implant, we thought that was just sort of an inconvenience that would be temporary, but it didn't work out that way. In Mississippi, our son was in New York, so what you get here are snapshots in time, is what we saw him. His wife, Carmen, of course, was with him every moment of every day for 2 years and suffered all of the things he suffered. But she can't speak because of a gag order, and it's tied to her financial settlement. She's the one who should be here and isn't. She knows everything that happened. Each time we would go visit, about every 3 or 4 months, we would see him, and of course, he would change dramatically every time we would go. I'm not sure all patients do this, but he rapidly became blind and deaf, and he had constant pain and vomiting. He became extremely weak and sleepy. He could last for about 15 minutes. but he always kept his interest in Carmen. He said he would keep himself alive to make sure that she was all right. And he did that. We admired him for suffering so much until the process ran its course, and she was finally taken care of. We met him for the last time at Christmas when he called us all together, his brothers and aunts and Donna and I. And we had Christmas with him. And it was very, very touching. One of his friends had sent a big box, and in the box was sand and 2 pails. And on the video that he made, he said, just lay back and put your feet in the sand and pretend that you're back in Mississippi where you should be. And Scott did that, and he wasn't hardly with it at that time. This is at Christmas. One of his problems was hiccuping. I don't know if that's, he would hiccup all the time as you're talking to him, violent hiccups. And of course, his jaw was calcifying, and his teeth were falling out. He couldn't eat. He didn't eat anything from the time he got the stomach implant until he died. And he used to like to eat. But he would go to Central Park, and he would sit on a bench and feed himself with the liquid meals that he would have. And that was remarkable for him to do that. The way it unfolded, he had 4 successful treatments. On the 5th one, it was a terrible onslaught to him. His head swelled up, and he suddenly became retching. His wife was there, and she got alarmed and asked them to stop the treatment, but they ignored her. And this went on for a 2nd time and then a 3rd time when the machine was wide open and he got blasted with unguarded amounts of radiation. The hospital, I think, made an error in that they told Scott that this has never, ever happened before, and that there must be something wrong with him because the machine always works perfectly. Of course, they found out that wasn't true. And that's when Scott went into this. He knew he was going to die. He and his doctor were very close. They were, and he went on kind of a mission to make his dying a cause for him to live for as long as he could. And he stayed all through all the suffering, and until finally there was a financial settlement, and he told me that Carmen was the reason he was staying alive. And at the Christmas party, I remember hugging him, and he whispered to me very weakly that Carmen is going to be all right, and he can die now. He says, I'm ready to go. And after we left at Christmas, he was very rapidly got much worse and soon died. It was traumatic for all of us, particularly his wife, Carmen. And she was wanting to testify, and of course she can't do that. And it's a shame that this is a secret that we aren't supposed to talk about. And that's why we're here. I told him I would do what I could. And what I did is wrote a scathing obituary for him, which didn't do any good. And I wrote a letter to the editor, which didn't do any good. And by some miracle, I don't know how it happened, but the New York Times picked up on this whole issue and has gone, and it's snowballed. I think it's making an impact, and that's exactly what Scott wanted. I'm sure he's up looking down, and he's very pleased. I would like to say that we are impressed with the machines. They're not as good as they could be, and they must be improved to where they're. We've made a couple recommendations. I'd like to quickly read them. We must develop a strong mandatory database that we don't have. And all medical institutions should report to the database, and it could become a repository for evaluating trends and identifying medical problems, all medical problems, not just radiation. The Veterans Administration has developed a reporting and system that reports and responds to medical accidents called NCPS. That's all I know about it. But it works in the VA system very well, and I think it would be nice if the whole country would adopt such a thing. We're very encouraged that the SBA has taken a regulatory role in radiology, and I understand the IMRT systems will be involved in that too. We asked the medical equipment manufacturers to develop a fail-safe interactive expert system that can interact with human technicians to reduce and eliminate human errors. I think that's what really killed Scott, was human errors. And the machines must talk to the technicians. And of course, the technicians should be very trained. Oncologists and supervising physicists must learn to micromanage their radiology departments. That's the only way they will work. If you don't do that, you're going to have people dying. It's outrageous to us that untrained and unskilled workers can get anywhere near this dangerous equipment. But they do, and it happened in Scott's case. Thank you.
Thank you very much, Mr. Parks, and also Mrs. Parks for being here. I mean, I know how tough, I know, it had to be tough for you to be here and give us your testimony, but it's really important because this is the very thing that we're trying to prevent in the future. So I don't know what to say, but to say that at least your being here in some way, can maybe make up in some way for your loss, that at least you're trying to prevent it from happening to others. Thank you.
Thank you.
Miss Lindsay, Miss Lindley.
First, I want to say how sorry I am for your loss, and that as a patient, I want to know.
Miss Lindley, I think you got to turn that on and move it closer to you, otherwise we can't hear you.
I'm sorry for your loss. And
I think it's still not on. Is the green light on?
as a patient, I too want to make sure that the safety.
I
and
don't
the
think
training
it's
is-
on. I hate to bother you, but is the green light on?
Green light's on.
Let me see if you want to try Mrs. Parks there, maybe?
As a patient, I too want to make sure that I'm in safe, qualified hands when I have treatment. And it's hard to follow a story like yours, especially when mine has been the complete opposite. Thank you for having me today. And As a resident of Canton, Texas, I'd also like to say a special hello to my fellow Texans on the committee, Congressman Green, Gonzalez, Hall, Barton, and Burgess. I'm honored to be here to share my experience as not only a cancer survivor, but as a patient advocate. I'm here because of cancer research, because of medical imaging technology, and because of radiation therapy. I was 31 years old when I was diagnosed with cancer. That was 11 years ago. It was then that I was diagnosed with stage 4 colon cancer. There are only 4 stages. Mine was the very most advanced. We found out that I had tumors that had already spread to my liver, and I was told that I had about 6 months to live. We were scared, we were sad, and we planned our first Thanksgiving as though it would be my last vacation on holiday with family. My daughters were 8 and 11 years old. We focused on the fact that I was going to die, and we very much lost sight of the fact that I would live. I posted a note on an online listserv asking for guidance from other cancer patients on how to prepare my 2 young daughters for life without me. And instead of answering my question, a gentleman wrote back, Shelley Weiler, and said that he too was going through stage 4 colon cancer and I should look for some hope. And that's what we did. I started with the only chemotherapy that was available. It was 5-FU, and it had been around for 30 years. I was fortunate that colon cancer research was rampant, and as my cancer progressed, I was able to benefit from each new treatment as it was developed. That worked for about 6 years, and then the cancer began to spread. There were no more approved options, so we went into clinical trials. And those bought me a little bit of time, too. Then my liver became just laced with tumors. They were multiplying to the point where it looked like the stars lit up the sky at night. My stomach was swollen, my skin was yellow, and I was tired. Every breath, every move was hard. And the doctor said that there was nothing else that they could do, and that basically I should call in hospice and that my condition was terminal. We prepared my family again, and I sent out an email to friends letting them know that I was at the end of the line. Then after calling hospice, planning a funeral, and picking out a casket, I got a phone call from one of the friends that I'd written a letter to, and he told me about his doctor in Wisconsin that was using selective internal radiation therapy. And they're little radioactive beads that are implanted internally, and they attack the liver tumors, and they leave the healthy tissue healthy. It sounded too good to be true, and so at first I was hesitant to call the doctor, and then he kept calling me a dozen times that day. And finally I picked up the phone, and I called the doctor, and we talked for a while, and it turned out that I was a good candidate for the treatment. I went back to my oncologist, and I told him about the procedure and thought he would be really, really excited for me. And instead he said, you know, I don't think it's going to help you. And then he turned around and said, what do you have to lose? No one knew how much I had to gain. I received the outpatient treatment called radioembolization in January 2005, and I call them little magic beads. After a 6-month period, we saw 65% of shrinkage, and then after a while, we started seeing necrosis of those tumors, so they were literally dying from the inside out. My belly started to get back to where there wasn't fluid in it. My color came back, and I began to live again. I learned how to scuba dive. I went skydiving. I started telling my private story in very public places. I connected with other people, and I met and shared experiences that I'd never seen if it hadn't been for this disease or these treatments. I've continued with systemic therapy, and I've also received additional targeted radiation treatments to stay ahead of the curve. I've had external beam radiation for tumors that spread in my spine, and that's helped me with the pain control, and it's given me better quality of life. I've had gamma knife used to treat a brain lesion. I've had radiofrequency ablation to treat a returning liver tumor, and I've had CyberKnife for lung tumors, and they've all given me a little bit more time with my kids. When you start anything new, and especially a new treatment, you hope for the extreme, you pray for the best, you prepare for the worst, and you don't really know what's going to happen, but all you have is hope. These advanced radiation therapy technologies have given me that hope. They've allowed me to watch my daughters grow up, to see them walk across the stage for graduation, to start college, and to become adults. They're 19 and 22 now, and they're both in college. These treatments have allowed me to walk hand in hand with my husband, and hopefully we'll have more of these treatments, and we'll be able to spend our rocking chair days together. I still have tumors here, there, and everywhere. Systemic therapy, after 11 years, is just now part of my normal routine. Along with that, I'll continue to use the targeted radiological therapies when needed. They allow me to live with colon cancer as a chronic condition and not a terminal one. These existing treatments and medical innovations will be a part of my life until there is a cure for this disease. What they have been able to give me is nothing short of miraculous. The grandest miracle is the realization that I'm not dying from cancer. I'm living fully in spite of it. I've reaped the benefits of research, a dedicated team of doctors, and increasing options. In my arsenal, there have been 5-FU, levamisole, leucovorin, irinotecan, oxaliplatin, Xeloda, Erbitux, 3 clinical trials, numerous surgeries, radiofrequency ablation, gamma knife, surspheres, and vertebroplasty. None of these, other than the 5-FU, existed when I was diagnosed. It is important that the momentum continue and that it is not thwarted, not only for me and for my family, but for the 1,500 Americans that will lose their lives today and each and every day after today. Before I close, I want to leave you with this one thought. As my personal story makes painfully clear, there are barriers out there already. And I realize that you're not trying to build those barriers and that you're trying to make them safe, but we also don't want to scare patients or take away their hope at the same time. Thank you.
Thank you very much, really, for being with us today and sharing that. We appreciate it. Dr. Smith-Binder? Bindman? I guess the name is spelled wrong there. I'm sorry, it says Binder.
That's how we spell it, though.
Right, Bindman, thank you.
Chairman Pallone, Ranking Member Whitfield, and members of the Health Subcommittee, thank you for the opportunity to testify today. My name is Dr. Rebecca Smith-Bindman, Professor of Radiology, Epidemiology, and Biostatistics at the University of California, San Francisco School of Medicine. I am a clinical radiologist, and my research focuses on assessing the risks and benefits of medical imaging. My testimony today focuses on CT because it's one of the most common imaging tests we use, and it's the test with the greatest potential for causing harm. CT uses X-rays to obtain extremely detailed images of internal organs, and the development of CT is widely considered one of the most important advances in medicine, allowing the more timely and accurate diagnosis of disease across every area of medicine. It is simply an extraordinary test, and currently 1 in 5 individuals in the United States undergoes a CT scan every year. Although CT scanning is useful, it delivers much higher doses of radiation than do conventional X-rays, and exposure to radiation can lead to the development of cancer. To help put this into context, when you go to the dentist and you're offered dental X-rays, some of you may pause to consider any potential harm from those X-rays. The most common type of CT scan that patients undergo in the U.S., an abdominal CT, delivers approximately the same amount of radiation as getting 1,500 dental X-rays all at the same time. Additionally, newer applications of CT, such as those used to assess blood vessels in the brain, require even higher doses of radiation, as much as 5,000 or more dental X-rays. The increase in the number of CTs and the higher dose for some CTs has resulted in a large increase in the population's exposure to radiation from medical imaging. The National Council on Radiation Protection, a group dedicated to ensuring that the U.S. population is as safe as possible as it relates to radiation, has estimated that the U.S. population's exposure to radiation from imaging has increased dramatically. The risks. Exposure to radiation increases a person's risk of getting cancer. The National Academy of Sciences National Research Council reviewed all of the published literature on the health risks of radiation. They found people who received doses in the same range as a single CT were at increased risk of developing cancer. Further, many patients in the U.S. receive multiple CT scans over time, and their risks are even higher. Thus, the doses that we experience every day as part of routine CT scanning are potentially dangerous. The cancers may not develop for 5, 10, or 20 years. Even though we can't see the harms immediately, we must take them seriously. Oversight for CT radiation dosing is very fragmented. The FDA oversees the approval of the CT scanners and medical devices, but does not regulate how the test is used in clinical practice. Radiologists determine how the CT tests are performed. However, there are few national guidelines on how these studies should be conducted, and therefore is great potential for practice variation that could introduce unnecessary harm for excessive radiation dosing. The American College of Radiology has established a voluntary accreditation process to try to standardize practice and collects dose information, but only on a very small sample of tests. This approach is promising, but at this point in time, the data collection is extremely limited, making it difficult, if not impossible, for the college to monitor if facilities comply with their guidelines. The manufacturers of CT equipment have begun work to establish standards of how radiation dose information should be measured and reported. However, the manufacturers have not adopted or implemented these standards. My research team at UCSF conducted a study to assess the doses associated with typical CT scans. We collected radiation dose on over 1,000 patients and found that for nearly every type of CT scan, the radiation doses were much higher than commonly reported, that the doses varied substantially between different facilities, and even within the same facility, the doses varied dramatically between patients. As part of the study, we also quantified the risk of CT. We found that for some patients, the risk of a single test could be as high as 1 in 100. That means of 100 patients who undergo a CT, one of them could get cancer from the test. This is an extremely high risk for a test that is supposed to find cancer, not cause it. What needs to happen to improve the safety of CT imaging? Given the importance of CT and, yes, its potential for causing cancer, it's imperative that we make CT scanning as safe as possible. To do this, we need to do two things. First, we need to lower the dose from routine CT scans, and second, we need to ensure that we use this technology only when necessary. To lower the doses, several steps are important. We need very clear standards for what are acceptable levels of radiation exposure, and there should be regulatory oversight for setting of these standards. Doses used in actual patients need to be monitored. Despite the potentially high radiation dose CT can deliver, there is no regulation of CT practice in the United States. The dose information should be prominently displayed when CTs are done, so that technologists can easily make adjustments if needed if the doses are too high. And lastly, the dose associated with each CT examination should be documented and recorded in each patient's medical record, and this information should be tracked over time. Recording and tracking dose information would help educate patients and providers about radiation exposure and would lead to activities to minimize dose. There are currently private businesses that offer full-body CT screening to healthy individuals. The FDA and most professional organizations have voiced concerns that using CT as a screening test could cause more cancers than they find. For diagnostic CT, these are tests that are done in patients who have a clinical problem, who have a symptom. It's generally been thought that if the patient is sick enough to get a CT scan, that the benefit of that test will outweigh any risk. However, we have started to use CT scanning so often, and in patients who are really not very sick at all, that we need to really think about whether the test is necessary and whether it could cause more harm than benefit. Neither physicians nor patients are aware of the risks associated with CT, nor the importance of limiting exposures. In summary, consensus is growing that efforts are needed to minimize radiation dose from CT and to ensure that patients receive the minimum dose necessary to produce a medical benefit. These efforts must include reducing unnecessary studies, reducing the dose per study, and reducing the variation in dose across patients and facilities. Despite the frequency and importance of CT imaging, there are no resources available to the research community to study or improve the quality of CT scanning. Creation of an academic consortium to study CT and make it as safe as possible would go a long way towards improving its utilization and safety. Thank you for allowing me to contribute to this important discussion, and I would be happy to answer any questions.
Thank you, Doctor. Dr. Klein?
Oops. Mr. Chairman and members of the committee, thank you very much for the invitation to come and speak here today. My name is Eric Klein. I'm a professor of radiation oncology at Washington University and have been a clinical medical physicist for 28 years. Over this time period, I've seen dramatic changes in terms of our profession's capability to diagnose and treat cancer. Our ability to image patients with modalities such as CT, MRI, and PET allow us to visualize tumors and involve lymph nodes with millimeter accuracy. We can now customize how doses are delivered to tumors by performing sophisticated calculations, allowing physicians to escalate dose to increase cure rates. Simultaneously, we can reduce doses to critical organs, even those close to a tumor. The delivery technique of intensely modulated radiotherapy, IMRT, which provides superior treatment delivery customization, comes with an increase in complexity and irradiation time compared with conventional radiation therapy, thereby increasing risk. Thousands of hospitals and private treatment facilities all over the country have purchased IMRT machinery, often for competitive purposes, and far too often without properly trained staff in place. Hospitals need to ensure staffing levels are adequate, not only in number but in expertise. There should be hands-on testing methods before therapists begin to treat patients, with testing on a frequent basis. The training for all staff involved should include the consequence if something is incorrect. There can be as many as 100 steps in each process, and each step must be understood by everyone involved. especially those steps with greatest volatility. We do a good job teaching people what to do and what to watch out for, but not the consequence or the impact if something is wrong. Though the anecdotal reported rate of errors in radiation oncology is quoted as less than 1 in 10,000, there are two problems with this quoted rate. First, it may be inaccurate, as there is no repository nor statewide mandate for reporting such errors. In many states, hospitals are not obligated to report errors occurring with their learning accelerator. A national repository for error reporting, anonymous or otherwise, should be instituted in order for the community to learn from such errors or even near misses. The second problem with this low anecdotal reporter rate is that it is still too high. Hospitals need to encourage scheduling patterns to allow for timeouts before each treatment begins to allow for cross-checking of all parameters by therapists. Related to this, the time leading up to a patient's first treatment should allow for careful review by the physicist of all parameters to be used. In addition, the manufacturer's testing of radiotherapy delivery and treatment planning equipment should include fault testing and compatibility between systems. In regards to medical physicists, we are the vital interface between physicians' orders and the eventual treatment. We are responsible for many things, including the accuracy of the images used for the treatment plan, the validity of the calculations, the quality of the resultant patient treatment plan, the accuracy of the linear accelerators delivery systems, and the overall end-to-end validation that each patient will be treated accurately. But having the intuition and wisdom to detect a potential or underlying problem only occurs with rigorous training. Medical physicists are educated in many important areas, and after proper training, ideally in an accredited residency program, may become certified by the American Board of Radiology, ABR. Starting in 2014, the ABR will only allow physicists who have completed a residency program to sit for the boards. This will raise the bar for the exam, thereby raising the competency of all medical physicists in the very near future. But the ABR has to wait until 2014 to allow the growth for the number of accredited programs for this to take place. The growth has been hampered by lack of funding. There are some funding mechanisms, but the most assured and balanced method would be for the Center for Medicare Services to provide reimbursement for training physics residents, similar to the method that's in place for training physician residents. And finally, there is an ironic situation regarding oversight of radiation treatment equipment. To operate a mammography unit and to be reimbursed for the procedure, a robust quality assurance program must be in place with oversight by a qualified medical physicist, and most importantly, programmatic overview by the FDA and American College of Radiology. This model of requiring a quality program and qualified personnel to be in place with review by an agency in order to be reimbursed for providing radiotherapy treatments should strongly be considered for radiotherapy as a profession. In closing, approximately 1 million patients per year are safely and accurately treated with radiation therapy, receiving outstanding and vital treatment. But further steps to ensure patient safety can and must be made. Thank you.
Thank you, Dr. Klein. Dr. McCullough?
Thank you. I do have some visual aids for some of the points. I want to thank you very sincerely for having this meeting today. It's an honor to be here, and I want to speak to you about the safety of X-ray computed tomography, most commonly referred to as CT scanning. Next slide, please. I'd like to begin by reviewing the differences go ahead, please, between the dose levels from radiation therapy and from diagnostic imaging. On the right there, the extreme high doses, such as what's required to effectively treat cancer, radiation can cause severe biological effects. In this high-dose region, the effects are predictable based on the dose that's delivered and can result in cell death, skin injury, skin reddening, hair loss. Next, please. In contrast, let's look at medical imaging, which uses a factor of 1,000 times lower radiation doses. At the doses used in medical imaging, there is a chance an effect might occur, but there is considerable controversy about the level of risk in developing a cancer from these low doses. Next. In fact, if we look at the risk levels, the blue line here is a relative risk of 1, meaning no increase in risk. And the vertical lines on the data points are error bars or uncertainties. The National Academy of Sciences report on the biological effects of ionizing radiation and the Health Physics Society state that these uncertainties, these error bars, do not support making any risk estimates below approximately 100 millisieverts. A CT dose is about 10 millisieverts. In this range, below 100 millisieverts, the risk is either so small or zero, but it's impossible to definitively measure. Next, please. So with regard specifically to CT technology, modern systems are equipped with feedback systems that will monitor the amount of radiation passing through a patient and reaching the detectors, and then it adjusts that radiation output throughout the patient and throughout the scan to adapt the amount of radiation so you get the image quality that is needed at the lowest dose. These systems automatically adapt the dose across within the patient, but across the spectrum of patient sizes, from children all the way up to morbidly obese patient. So here's an example of an automated setting taking the dose from the adult level, which would be about 165, and it tailored it automatically down to a child level. Next, please. I'd also like to point out that the patient dose for a single CT exam of the abdomen, chest, abdomen, pelvis is a factor of 2 or 3 times lower now than it was 2 decades ago. The current technical innovations continue to drive doses lower. Next click. Even though throughout the years the image quality keeps getting better, these numbers here, the section width is the thickness of anatomy represented by one image, and we continue to get thinner, which gives higher detail, better image quality. However, CT is a sophisticated medical device, and as with any device or procedure, human errors or electrical mechanical errors can happen. And that's why I'm very grateful for the interest of the committee, the FDA, and the whole imaging community in ensuring that medical imaging is performed as safely as possible, whether or not the exams involve ionizing radiation. Next, please. I believe that the technology is not our fundamental problem. I believe that the concern is of education for the technologists that operate the equipment, the medical physicists who test the equipment and optimizing it, and the radiologists who prescribe the exam protocols. The education has not been able to keep up with the rapidly growing changes in technology, and the single most important factor to make this more safe for our patients is to ensure that all personnel involved in operating medical imaging systems meet nationally prescribed minimum levels of training and competency. The needed accreditation and certification programs already exist, but without mandatory requirements for a consistent level of education, we're allowing, in some cases, inappropriately trained personnel to operate some extremely advanced medical equipment. Next slide. One of the examples of the educational efforts being made by the imaging community is a dose summit by the American Association of Physicists in Medicine. We're having this in April this year. We organized this to teach users how to adapt the scan protocols to make sure that they're appropriate for the diagnostic task and for the specific patient. The faculty and the attendees include physicists, radiologists, technologists, and regulators. And the meeting is being contributed to by a large number of professional organizations in the imaging community. Of note, the registration is capped at 200 participants, and the meeting was sold out within 1 week of registration going live. Next slide, please. So in summary, today's medical imaging, as you've heard, as you're well aware, has some absolutely amazing technology. It can non-invasively diagnose and guide treatment for injuries and diseases that couldn't be accomplished in any other way. Without CT, there would be more unnecessary surgeries, such as for suspected appendicitis that didn't turn out to be appendicitis, more invasive diagnostic tests, and less effective treatments. Before the advent of CT, exploratory surgery was not uncommon. But clearly, medical tests, whether it has ionizing radiation or not, should only be performed when they're medically appropriate. When they are, the benefit far outweighs any potential risk. In fact, there is a very real risk to the patient's health if the necessary medical information is not obtained. Unfortunately, right now, the patients are being frightened by the media reports about the dangers of radiation. We are seeing patients come into the clinic with symptoms of potentially severe illness or needing life-saving surgeries or treatments who have refused their CT exam because they've heard on TV or in the papers about this cancer-causing stuff. They are being harmed because of not getting the needed medical information. Patients and loved ones should not...
I'm going to ask you to wrap it up only
Okay.
because I know some of the members aren't going to be able to stay.
Okay, I'm on my closing right here. So
Okay.
patients and loved ones, I think, shouldn't be concerned about whether or not the image exam is being done properly. We should take care of that with training. They should be concerned about whether they need it. When my 11-year-old daughter ended up in the emergency room and the ultrasound showed potentially lacerated spleen, they went to CT for the definitive diagnosis. It was normal, thankfully, and I don't think that was an unnecessary exam. It saved us from having unnecessary surgery. Thank you.
Thank you, Doctor, and I agree with you. I'm going to pass and have Ms. Eshu go first because I know she has another commitment.
Thank you, Mr. Chairman. It's called the commute to California. Hopefully getting the plane, but I didn't want to leave you. First, I want to thank each of you, the witnesses, starting with Mr. and Mrs. Parks. I'm a parent, and it just should not be the case where parents bury their own child. So what you have done in coming forward today is enormously helpful to us, and it's painful for you, but I think that what you are doing in the name of your son is an enormous contribution for us to really address and get to the heart of what has happened, and that would be the greatest tribute to him. So I want to thank you, and to Miss, is it Lindley? I think that you've articulated so well what these technologies bring forward and the hope that they represent, and your own example. And by no means does anyone on this committee want to put a dent in what we have produced in our country that is, in so many cases, second to none in terms of the application of the technologies that are life-saving and life-extending. And I think that what you said really points to that, to the professionals, to the doctors that are here. It's wonderful to have someone from our region, from UCSF. Absolutely terrific. Let me just make a couple of observations. We have, it seems to me, in looking at all of this, that we have safety procedures and oversight that need to be addressed. That we have obviously 50 states, and we have a patchwork quilt of regulations. There isn't any consistency that I can find in terms of what I've read. There's the whole issue of proper supervision. Radiation is life-saving, and it can kill someone. So, I mean, this is something that needs to be supervised, and there has to be proper supervision, but there also has to be education and training in this, and we don't really have any national standards on that. One of the doctors mentioned the practice variations that exist, and there are really no standards across the manufacturing field. Accreditation. I mean, I don't think there's any national standard relative to accreditation. What I'm stunned by is that there aren't more cases that Mr. and Mrs. Parks coming in. Thank God. But this is really sent up the red flag. So what I'd like to ask is of the professionals, of the doctors, A, would you recommend national standards in these areas? I can't help but think of the Mammography Quality Standards Act that one of the staffers, and it's in our staff report here, that many years ago we were facing with mammography. And the Congress stepped up and put that law on the books, and it addressed many of the issues that we're talking about here today. Do any of you disagree about national standards needing to be addressed? So you all agree. Do you believe that there should be accreditation in this area and licensure of those that administer the radiation?
In CT, the American College of Radiology has an accreditation program that's not mandatory by regulators, but has become mandatory in a de facto sense because the insurance companies started requiring it in order to get reimbursed. And so the program actually has thousands of units that are accredited. The program does address dose. We measure dose. We have a database of dose. And as part of that accreditation program, I have seen it continue to raise the bar of quality in CT since its inception in around 2001.
Now, what again from the doctors? What responsibility do you believe the manufacturers have in this? What positive role can they play? Where do you? I mean, maybe this is a sticky wicket for you to be telling us, but I'm not on a hunt against anyone, but it seems to me that we've got to examine each facet of this. And if you think that there's an important role for them to play in this and what that would be.
I think in the area of diagnostic medical imaging, we have very little data about what is currently going on. So
what does that mean, going on?
It means that Dr. McCullough told us that a CT scan has a dose of 10 millisieverts. When we went and collected dose information, in fact, the doses were 2 to 3-fold higher than that on average. And for one patient, the doses ranged, for one type of problem, range from 5 to 100 millisieverts for the kind of test that's supposed to have a dose of 10. So, in fact, we don't know what's currently going on. The doses in general could be much higher than we think and more variable. Part of the problem is there's no organization collecting dose, documenting dose, and part of the difficulty in that is the standards for reporting dose vary across the board. So there's no consistent way that dose is reported that a radiologist could easily look at the information on an individual scan and understand. So you asked about the role of the manufacturers. There are several very important committees that over the last several years have agreed upon standards for reporting dose information, for putting that information in the medical records. These standards have not been adopted by the manufacturers. If these standards were adopted by the manufacturers, we could quickly know what's going on and then determine how closely different facilities abide by those guidelines that we would put out there. So we need guidelines about what's allowable, and we need data to decide if places are within those guidelines. So I think the manufacturers could enormously move this field forward by adopting these standards immediately and having this data.
That's very helpful. I know they're going to testify at the on the next panel, but I won't be here, and we definitely need to work with them. Dr. Klein, did you want to add to that?
Well, I'd rather have Dr. McCullough respond.
Okay, great. And then
I do have a slightly different perspective
I'll yield back.
on this. There's an organization called the International Electrotechnical Commission, and it's a trade organization that's worldwide that the U.S. participates in through National Standards Institute and NEMA. And that organization, the IEC, actually sets very well-prescribed standards about how the radiation output of a scanner is to be measured. And the scanners, in fact, in Europe, can't even be sold with some of these. So in the U.S., we have the same IEC labeling, if you will, on all our scanners. And the value of the dose output of the scanner is actually shown on the console. It's mandatory that it be shown before.
Who reads that?
It's right in front of the technologists. And it's
They do read that before they use it? Really?
It's in front of them.
Well...
And one of the things is the protocols tend to be prescribed for a given patient and diagnostic task, and the variation that you're hearing about, radiation gets stopped kind of quickly in tissue, so every 4 centimeters of extra thick that a patient is, you need to actually double the machine output to get the same image quality. So from a thin, perhaps Asian woman to an obese patient, that's a factor of 64 in what...
Yeah, I have to tell you, I mean, you're absolutely brilliant. You know this better than anyone. That's why you're one of the expert in terms of testifying. But to suggest that that the knowledge is somehow transferred through the system because there's a sticker or something on the equipment doesn't do it for me. I have to say that. But thank you very much, Mr. Chairman. And this is going to require some work of our committee, but it's what we're here for. And I think that with the people that you have assembled, and we need all of you to be part of the I'm sure, legislation that we will draft and pass, and it should be bipartisan. This is something that knows no partisanship, because it could be me, it could be you, it could be any one of us. So thank you very, very much.
Thank you, Ms. Eshu. You can continue, Dr. Klein.
Well, in regards to radiation oncology equipment and manufacturing responsibility, certainly the machinery goes through quite a bit of testing as when it's in the factory and as it gets delivered. What could be done better is the training for the users, fault training, to demonstrate if this message shows up, this is exactly what it means. And some of the manufacturers are inconsistent on some of the testing that they perform with the users, with the physicist. One company does a very good job, for example, of forcing errors to happen and then watching that the machine will stop and show you what that error is, but it's not consistent. And the other problem that is a wide variation is problem reporting, how errors or how machines that aren't functioning properly, how that information gets to all the users. It varies, again, how we get that information. Unfortunately, sometimes it's anecdotal or list servers, rather than direct communication to any potential user of this equipment. It might be better to do overkill communication right now, which is scant and irregular. Thank you.
Thank you. Mr. Whitfield.
Well, Mr. and Ms. Parks, I also want to thank you for being here today and sharing your son's ordeals with us. We appreciate that. And Ms. Lindley, thank you for being here as well. When we talk about medical imaging, it's rather limited. I mean, we talk about CAT scans, MRIs, X-rays, and that's primarily it. But then when we talk about radiation therapy, I'm assuming that would there be hundreds of radiation therapies? Or I know we have linear accelerators, we have gamma knives, we have, Dr. Klein, would you help me with that about the different kinds of radiation therapy?
Sure. The main core of patients are treated with linear accelerators, which come in some different differences. There are, the far majority come in machineries that can deliver what are called photon beams, deep penetrating, and maybe with or without a beam called electrons, which are not so penetrating. And then there are very customized treatment delivery equipment with external beams, such as was mentioned by Ms. Lindley, the cyber knife and gamma knife, which are very specific for specific sites. There's also the use of actual radioactive sources directly placed in the tumor for a technique called brachytherapy, which again was what happened with the VA hospital, was a form of brachytherapy. So there are variations, but the core of patients are treated with linear accelerators.
Okay. And when we talk about beads being placed, what is that?
Those would, I'm certain that those must have meant radioactive seeds, which are placed directly in the tumor. Sometimes they're given over a few days or 5 days, or sometimes they're left in permanently.
Okay. Well, let's take a linear accelerator for just a moment. Of course, we have the manufacturer involved because they made it. Typically, how many people would be required to be on the site when the linear accelerator is being used as it was on the Parks' son?
I would say for the most part, two radiation therapists are at the console. There can be 3, hopefully not 1, although I have witnessed that on some occasions.
So 2 radiation therapists.
Yes.
Now, are radiation therapists medical doctors?
No, the word therapist does throw people off. These are radiation technologists who've had the education to become radiation therapists and treating patients, but they go by the name therapist.
Well, I know that from reading about Mr. and Mrs. Parks' son, it appears that his injury was sustained because of the filters. The filters were not calibrated or adjusted in the proper way. Is that?
What happens with regular radiation therapy, conventional, is that there's an open beam that treats a patient. With intensely modulated radiation therapy, there are devices, little collimation devices that move in and out of the beam, which gives it this very customized way of delivering therapy. And so if those aren't in place, then the results again can be problematic.
Well, from the testimony of...
I'm sorry, and that's because the irradiation time, the time it takes to deliver IMRT, as I mentioned in my testimony, is longer than conventional therapy because the beam, for the most part, is being blocked.
Right.
So it creates extra time.
Right. Well, from the testimony, you all can correct me if I'm wrong, but it appears that the recording of errors, the doses being used, the sharing of information to the people that should know it, it appears to be really a fragmented system that I'm assuming would vary greatly with every institution. Would I be correct in that assumption?
Yes, certainly what an institution does from institution to institution and how they handle errors, what type of database they have and how they examine and report back to the entire staff, I know will vary considerably.
Yeah.
And then obviously from state to state and so forth.
Well, you know, I'm really glad we're having this hearing because all three of you had indicated that you do feel like there does need to be some national standards to assist in this area. And when we're dealing with equipment like this that can certainly provide healing powers and do miraculous work, it can certainly destroy a person as well. So your testimony has really been helpful, and I do thank you, all three of you, for being here. Let me ask Dr. McCullough one question, just out of curiosity. Now, this is not anything technical, but I noticed that either in your testimony or in your resume that it talked about College of Medicine, and I wasn't, I guess I should have been aware, but I wasn't even aware there was a College of Medicine at Mayo Clinic. I mean, I know you have residency programs, and
We have a medical school also.
there is a medical
Yes,
school. And
that's where our academic appointment.
And how many students do you have there?
I don't know offhand. It's a relatively small class size, probably 50-ish, 50 to 100.
So this would be interns or residents or undergraduates or all three?
Well, the medical school is to train physicians.
Right.
The residencies would be physicians in their specialty training. We have PhD programs,
Okay.
and we train technologists and allied health.
So you have the whole gamut then?
We try.
Okay. Thank you.
Thank you, Mr. Woodfield. I'm going to ask some questions now. I wanted to first, again, I don't know how I could thank the Parks enough for being here and, you know, for relating the story of your son. It's just, it's really a sobering reminder of, you know, why we're here today, frankly, that you're relating to us. I just wanted to ask Mr. Parks, you mentioned the error reporting. Why is that so important, if you would? You mentioned the error reporting, you know, that when they report the errors, you mentioned that. Why do you think that's so important, the reporting? Again, I got to ask you to turn that, yeah.
My understanding is these machines have like a focus, and ordinarily it seemed to me they should be shut so that they can't kill anybody. But in this case, it was wide open, and it was wide open at 3 days in a row where the physicist didn't check the machine. Nobody did. And in the little we know about it, there were 4 unauthorized, untrained people who fiddled with that machine during those 3 days. And that's, can't explain that. I don't know why that happened.
Okay. So your view, you're basically saying is if there was more supervision and these things were reported, then we might prevent it.
Yes, the physicist, it's our understanding, was gone. She went somewhere to a meeting or to a seminar or something, and left. There was no one else qualified there. They should not have run the machine if there's nobody who couldn't run it. But they did, and there needs to be enough staff to where there's somebody all the time watching that machine. Also, we found that the ones that were there were watching the monitor, and apparently they give them some sort of medication that makes patients vomit sometimes, and his face was covered with a mask, and they were watching to make sure he didn't vomit into the mask and aspirate. They weren't watching the monitor that was telling them that something is wrong, but they didn't look at it. They didn't look at the monitor. And he didn't vomit, of course, but there was just inattentiveness there.
Okay. Thank you. Thank you so much. Ms. Lindley, you know, I think it's, I mean, obviously you said and I've said that it's critical that these technologies be available. But you also, do you also think that more needs to be done to make them safer?
I think I've been in pretty safe.
Maybe let me get the mic again there.
I've been in pretty safe hands, and I think that especially with the selective internal radiation therapy that I had, which was the implanted radiation, they did, after I had the procedure, they actually took me back and did a SPECT scan to ensure that the radiation was in my liver and that everything was good. And so with it, I was very confident. After I read their article, I know that the next time I have a treatment that I'll definitely ask more questions, and I think it's good to be proactive.
All right. Thank you so much. Let me ask the three doctors. I know time's running out here, but I wanted to ask the three doctors a question, and this gets a little complicated. But if we look at ways to improve the system, there are two major models that I know of. One is the Mammography Quality Standards Act, which I guess I'll call MQSA, and then there are changes in the Medicare Improvement for Patients and Provider Act, which is MIPA, I guess. I hate to use these acronyms, but I have no choice. And my understanding is that the MQSA is much more detailed and sort of aggressive. That's sort of a general statement on my part. There's no accreditation required for radiation treatment facilities, no licensing requirement for personnel. So let me start with Dr. Klein. You mentioned the mammography standards in your testimony. I guess that's the MQSA. You know, I believe in the importance of these standards, but the question is, you know, is radiation therapy too complicated or too diverse for Congress to regulate it the way we're doing with the MQSA? I mean, would you think that we could go that route, or you think we should just leave it up to the practice of medicine?
I think because of its complexity, it's even more necessary to have oversight and to have accreditation for facilities.
So would you use the MQSA model?
Not exactly that model, but what it's trying to accomplish, yes. It's uniformity, that all mammography centers are giving the lowest doses possible to get the best images. And I think that philosophy can be carried forth, that every facility, before it turns on a beam, has been checked, and the personnel know exactly what they're doing.
Okay. Now, can I make a distinction between, you know, the mammography standards, the MQSA, and the MIPA in your mind, and, you know, whether you think one is a better model than the other?
The MQSA model is very prescriptive in terms of the credentials that each member of the healthcare team needs, in terms of the quality assurance program, how frequently it needs to be performed. And in that sense, the sort of consensus of the professionals in the community were able to give a set of best practices. I'm not familiar as much with the MIPA, but my understanding is that it's not got as in-depth and prescriptive credentialing requirements for the staff, for example, certainly not gone into the detail with the quality assurance.
So you would be more inclined to use the more detailed or aggressive model of the MQSA. I hate to, you know, I'm using my own terms here to describe it, but you would be inclined that way.
I think it's been a very good program. Certainly there's, you know, a lot of overhead that comes with it, so we would just want to be very, you know, cautious as we move forward that we, you know, do the best without adding too many levels of extra steps.
Do you want to comment, Dr. Smith-Bindman?
I do. A lot of my research focuses on breast cancer. So I know the MQSA rules and regulations in detail, and I know the impact they've had on the quality of mammography cannot be overstated. Mammography has improved profoundly since the enactment of MQSA regulation. And one of the things that's so wonderful about this is they actually follow what happens at the patient level in terms of what they're likely to get when they go for a mammogram to ensure that it's of a high quality. So I think there's probably a role for both of those in oversight, but MQSA has improved both the technical quality of mammography, and it's also improved the interpretation of mammography by having agreed upon standards by which these exams are done and interpreted across the country. And so the impact has been really phenomenal on the quality and improving women's access to high-quality mammography.
Now I'm out of time, but let me just ask one more thing since I'm on this. Now, CMS is currently implementing the MIPA standards. So I guess one could say, should we see if they're fully implemented before we, use them as an example?
I think it's very important to think about what accreditation is going to do. And I think if accreditation is going to put some general standards out there, that's absolutely a move in the right direction. But what you really want to make sure is that every patient at every facility is safe and getting the best quality exam they can. And I'm not sure an overview of accreditation will give you that. So I think it's certainly a place to start. It makes no sense to have facilities that are not accredited as long as we make sure that accreditation actually gets at quality. But I think in addition to that, we also need some safety measure to make sure that we're actually getting the highest possible quality out of these tests as possible.
All right. Thank you very much. Mr. Green.
Thank you, Mr. Chairman, and like everyone, I'd like to thank all our witnesses, and Ms. Lindley particularly, as I say to my colleagues on the committee, you and I don't have to have an interpreter to talk since we're both from Texas. But thank you for bringing this up, and I've watched them because some of us have served on the committee for many years, and healthcare is as much part of my life as it is a physician's, I think, because our goal is expand access. And over the last 2 years, when we've seen what's happened, and to take away that trust that both patients and families have in some of the technology we have, that's what worries me. Because I look at it, and y'all heard my opening statement that in medical technology, we're growing every day in our ability. I know on our next panel's a staff member for MD Anderson, and I've been there and watched what both as it was being built, but also their laser treatment facility there. It's amazing what can be done today that used to couldn't be done simply because surgery couldn't do it. And that's why I'm so concerned about making sure we get it right so we don't take away that growth in the technology that makes us healthier people. Dr. Klein, can you describe the latest advances in radiation therapy? And like I said, having been to MD Anderson a number of times, I know my local one, but I know there's also great facilities all over the country.
As I mentioned before, there are numerous variations on linear accelerators. And what's been the most exciting addition to these linear accelerators has the ability, as the addition of imaging devices actually within the treatment room. And this has had a huge impact because now we can capture exactly how the patient is setting up, and for that matter being maintained in the right position during treatment. And this is very important. So and this is what's known as image guidance radiation therapy. So this has helped us improve our accuracy of setup and also how the patients are being treated throughout the course of a given treatment. The other new technology that's starting to boom, of course, is proton radiation therapy. These are large facilities that deliver a very different type of radiation therapy, very customized and idealized for pediatric radiation therapy, for example. So these are some of the new things that are coming, and nothing should ever stop these from happening. Again, but the people trained to use them and how they're used, again, needs to be looked at with scrutiny.
Well, I know there's a difference between radiation that maybe we've all been accustomed to for decades, but compared to what's happening today, whether it be proton or even heightened usage of radiation, can you just talk about that, the difference between what has happened in the last few years on treating particularly cancer?
Being not a physician, I think almost every tumor site now, and when I mean site, I mean by site of the body, has has found a way to be treated with radiation therapy more uniquely and customized. For example, not every patient is a great candidate for intentionally modulated radiation therapy. There's some that still benefit from conventional therapy. But certainly, for the most cases, IMRT has improved our ability, because a lot of these tumor sites are in locations that happen to be right next to a critical organ that we don't want to give any dose to. And lately, we've been able to give, again, the curative doses we need to those tumors while not giving the dosage that would cause problems to the organs nearby. And that has only been improving over the last 5 or 10 years.
Okay. Well, and I know, having heard Mr. Parks, and again, what happened to the Mr. Parks' son just seems like we ought to be able to prevent it. But can we do better on reporting the error? Although we know there is reporting, because otherwise we wouldn't be here today, because we see it in lots of different varying facilities around the country, even a VA facility. So is it, do we need to do better on reporting error so we can make changes or corrections sooner?
I always think of error reporting in two flavors. One is anonymous reporting, reporting that someone sends in an error that had happened with this particular machinery and does an analysis of why it happened, but they do it anonymously so that they're more likely to do that because there wouldn't be any direct liability. Now, the airline industry learned that was a great way to go for learning about incidents and near misses too, not just incidents that happened, but ones that almost happened, and everyone learns from that. And then, of course, there's the other error reporting for an actual damage to a patient, and they sort of both have to happen. But again, you can learn certainly from both. But anonymous reporting is something that we need to consider. And a lot of facilities are reticent to do so because they're afraid they can clearly submit an anonymous report without getting into trouble.
Okay. Well, and I know from other members' questions on both sides of the aisle that it's not something we may be able to do voluntarily, the industry to regulate itself. It sounds like we actually need legislation to deal with it. Is that correct?
I think if we go to the step of having every error reported as mandatory, then it obviously has to come from an agency. Now, the Nuclear Regulatory Commission does that right now. If you're in a state that is where the isotope use of the radioactive materials is still governed by the Nuclear Regulatory Commission. Not every state has that. 2/3 do not. But in Missouri, if an error were to happen with use of an isotope for radiotherapy, such as gamma knife, we absolutely have to report that. Okay. But if an error happened with a linear accelerator in Missouri, we wouldn't have to report it to anyone.
Okay. Well, Mr. Chairman, it sounds like we have some ideas on what we need to deal with on legislative. Thank you. I know my time's run out.
Thank you, Mr. Green. Ms. Castor.
Well, thank you very much, Chairman Pallone, for calling this important hearing, and thank you to each and every one of you for being here today. There have been such tremendous technological advances in medical treatment, but along with these advances come increased hazards when the equipment malfunctions or is improperly set up or used incorrectly. And as the equipment becomes more powerful, I think we would all agree that it's imperative that everything possible be done to minimize the risk of something going wrong. And there was a terrible case in my hometown at the premier cancer center that has a sterling reputation. It's just outstanding. But unfortunately, and this was a few years ago, 77 brain cancer patients were over-radiated because a newer, more advanced machine had not been set up correctly. The problem wasn't discovered until inspectors from the Radiological Physics Center, a federally financed testing service, came in for an inspection. And the director of the Radiological Physics Center said that if the inspection occurred earlier or if the centers had a regular practice which included inspections earlier, we really could have avoided these terrible errors. So I know you all have called for greater training, broader accreditation, but on this narrow topic, what about the folks that come in and install, the manufacturer's representatives? Do they bear some responsibility of catching these errors, doing that testing, should accreditation programs include the manufacturer's technical representatives. Dr. McCullough, you want to start?
It's incumbent on the facility to actually have one of their own physicists or a hired physicist or something to test as an independent measure, because the equipment manufacturers come, make sure it's operating according to specifications. But then there's what I assume happened in this case, the secondary test that the in-house people measure and calibrate it and set it up for their uses. So I think duplicate systems are always good, checks and balances. And so the manufacturers make sure it's operating. The users then have to make sure they set it up correctly and use it correctly.
Yeah, because
so
according to their in-house test, it was operating adequately or acceptably. And it wasn't until the Radiological Physics Center came through again that they noted the errors.
I think that it's very important to know how the machines are used in actual practice, not how they're used before they leave the factory. And the manufacturers, when they come in to set up every CT scan, for diagnostic imaging at least, they work with the local physicians to figure out how to set up those scans. And it turns out it's a complicated topic, but you get prettier pictures if you turn the dose up higher. And those default settings are crucial in terms of what most patients receive. And if those default settings are set in such a way that you get the most beautiful pictures, then it turns out the patients are getting higher radiation doses than they need to support those pictures. So one of the things that the manufacturers are on the ground doing is setting up those protocols with the physicians, and there should be guidelines for how those default settings, the settings that most patients experience, are set up. So I'd say that's one way the manufacturers could help ensure most patients receive the lowest dose possible. Second, this awareness of the potential harm for radiation is currently getting a lot of attention, and the manufacturers actually have a lot of ways to lower dose. So the doses for the most typical scans that patients undergo could be reduced by 50% without reducing quality at all. And there are lots of ways to make that happen. Dr. McCullough is an expert on how you make those parameters as low dose as possible, but the manufacturers have a lot of expertise around that area as well. They have algorithms that you can apply to existing machinery to lower dose. And I would really push for the manufacturers to make those software products available to everyone who currently owns a CT scan and at a reasonable price so that we can get those dose reduction algorithms out there in active practice. I think on the newer machines that will be sold over the next 5 years, this problem may be addressed to a greater degree, but I think we really need to ensure the current scans that are out there are done, and there are ways to lower dose dramatically.
In regards to radiation therapy, and in particular maybe to what happened in Florida, that the manufacturer did not have any control over the training of the individual who was responsible for determining how the machine was designating the dose rate, and that's where the problem was lying. The manufacturer did not have control to that the physicist who was responsible would have demanded, and we drive our manufacturers crazy, to do extra tests to validate that everything was going correctly. However, if the manufacturer had said, okay, you're buying this very expensive piece of equipment, it's complex and it's potentially dangerous, we are going to supply an expert physicist to come in from the outside to validate what you're doing. Very simple solution that it would have caught what had happened.
Thank you very much. Now I'll yield back so we can get to the next panel.
Thank you. We're not going to have a second round because we have to go to the next panel, but Mr. Whitfield, who's been here by himself on the Republican side, would like to ask some questions, so I'm going to let him do so.
I want to thank you for your sympathy and understanding. When we talk about federal guidelines for accreditation and reporting of errors and so forth, I want to ask you three physicians, do we have to be concerned about HIPAA regulations when we get into that area?
I think one of the problems in easily collecting data are that you don't want to release information about the patient and privacy information that would be concerned. As it turns out, for the area that we're talking about, you don't need to release any private patient information. To understand dose, you need to know a little bit about that patient, such as their age and their sex. None of those are covered by HIPAA, and the dose that they received. And that's all you need, and none of that data are protected under HIPAA. So I think we use that sometimes as an excuse for not collecting the data, but in this particular area for diagnostic imaging, we don't need any of that personal data to understand quality.
And, okay. Dr. Collins.
There are some databases right now that have a data bank of errors that have been reported, the IAEA, and there's also an interesting group, European group, called ROSIS, R-O-S-I-S, and I can supply that information later. It's all voluntary, and everything is anonymous in terms of the patient information, and it works very well to learn from that system. So I don't think it's an issue, really.
Okay. I mentioned to Chairman Pallone that if he's going in for radiation, he better have his own checklist to look at. And then, we started thinking about that a little bit more, and I think that's one of the problems with our medical system today is frequently patients go in and they just make themselves totally compliant to whatever is going on in there. And should we pursue that in areas like this that have such dire consequences that the providers provide the patient or the patient's family with a checklist that they should be focused on as they go through their treatment?
What we're basically asking is there anything you can do proactively as a patient to check what's going on? If you go in, can I ask some questions about what's going on here to make sure that I don't get overexposed?
One of the things we encourage, we have a patient information brochure at the check-in desk after you've agreed with your physician that this is an important exam, is just to make sure your physician is aware if you've had any exams recently, because perhaps the one you're having today isn't necessary. But also we encourage, in general, the topic of just making sure that the institution knows that they need to right-size the dose, so to speak. Is this exam being tailored for my particular illness or diagnostic question and for my particular body size, since we all come different shapes and sizes?
Sure, go ahead. That whistling, I think, is the win. It's not somebody holding a whistle.
It's a win situation, although for diagnostic imaging, if you went in as an informed patient and said to the technologist or the physician, can you tell me what my dose is on this exam, the answer currently would be, I don't know. I've received dozens of emails and letters and phone calls from patients who were really very concerned about this, and one described his experience of asking his physician about the radiation dose, and he was told by the hospital that he could hire a private physicist if he wanted that information. And that information is in the CT scan, albeit it's a little tricky to get out, but I think that information belongs in that patient's medical record. So if you as a patient go to the emergency department and they need to give you a medication, there's a big sticker that goes on your chart if you have an allergy to a medicine, and we've tried to put checks and balances in place to make sure that if you have an allergy, you don't get that medication. I think around the issue of radiation safety, we need to start thinking about that way. So when a doctor sees you and orders a test, they know if you've had 15 others of those tests in the last 2 weeks. They might still get that test, but that information would be very important. So if information is in the medical record, I think doctors could make more informed choices. Certainly a patient should keep track of everything they've had done and ask the right questions, but we need to have a system in place at the other end that there are answers and information that they can get back.
One of the, if I could...
Yeah, go ahead, sure.
One of the difficult things about saying the dose is that the equipment and what the manufacturers can do is say, what is this machine putting out? The actual dose to the patient then gets much more complex because it's this interaction of the patient, their body size, with what the machine is putting out. And so the data is very clear as to how the machine was set up, and then a physicist can go back and make estimates and models of what that patient got. But unless you went to the extent of almost radiation therapy treatment planning on each and every patient, you really can't tell them what your liver dose or your lung dose is without actually having a full CT of their body and then modeling what the scanner gives with them. I don't think I did a great job answering Ms. Ashu's question about is this information available? And the number that's available is what the scanner's set up to give for a standard patient. Our technologists look at that rigorously, religiously, and that tells them, have I set up my exam correctly? Are all my parameters typed in? And then at that point, the scanner adapts to the patient size. Mammography systems do this, fluoroscopy, radiography, because the math that's involved of figuring how much is getting through this size patient or that is something you can't kind of do on the side on a calculator. So most radiographic systems actually have that feedback loop, and that's where you can't explicitly say what Mrs. Smith is going to get in her liver, because it will take the scan of Mrs. Smith and give the feedback of just how big she is to set the dose.
All right, thank you very much. So this was very instructive, and I know that several members have said, are we going to do legislation? Do we need follow-up? We could easily, after we have this hearing today, decide that we need additional hearings or get back to you, and you may get some additional written questions within the next 10 days or so. So thank you all. We appreciate it. And thank you, in particular, the Parks and Ms. Lindley as well. Thank you. We're going to move to the second panel. All right. Looks like we're very crowded here. I didn't realize that you're going to be rubbing shoulders. So let me start with our second panel and introduce the panelists from my left to right. First is Dr. Tim Williams, who is chair of the Board of Directors of the American Society for Radiation Oncology. And then we have Dr. Michael Herman, who is president of the American Association of Physicists in Medicine. And then we have Sandra Hayden, who is Vice Speaker of the House for the American Society of Radiologic Technologists. And then Dr. Stephen Amos, who is former chair of the Board of Chancellors for the American College of Radiology. And then from New Jersey is Kenneth Misrak, who is director of the VA New Jersey Healthcare System and within the Department of Veterans Affairs. And then we have David Fisher, who is executive director of the Medical Imaging Technology Alliance, and finally John Donahue, who is Vice Chairman of Medicalis, Inc. Thank you all for being here. I think you were all here before when I said 5 minutes, and your full statements become part of the record, and then we'll have questions. You know, I don't know if I apologize. I mean, I know when it's a Friday, of course, if the votes are over, we don't have as many people participate. But, you know, we had originally scheduled this for a day when it snowed, when we had all the snow. So when we tried to reschedule it, we didn't have a lot of options. So that's why we're here on Friday. And we'll start with Dr. Williams.
Thank you. Chairman Pallone, Representative Whitfield, members of this distinguished committee, good afternoon, and thank you for the opportunity to testify at today's hearing. I'm a practicing board-certified radiation oncologist, and I've been in my location for over 20 years, and I've personally taken care of almost 7,000 cancer patients. I care deeply about the health and safety of my patients. ASTRO wants patients to have peace of mind when it comes to safety, quality, and efficacy of radiation therapy. We are committed to stronger error reporting, enhanced accreditation, better use of health information technology, patient-centered educational tools, and federal advocacy to help protect patients. I was not involved in any of the tragic situations described by the New York Times, but I want to offer my own personal sympathies to those families, and particularly the family of Scott Jerome Parks, whose father shared his story with us earlier. His wish was that no one else would go through what he did. We agree. No medical error is acceptable. Cancer patients have enough to worry about. I've personally witnessed the great benefits of radiation therapy for cancer patients as the medical director of the Department of Radiation Oncology at the Lynn Cancer Institute of Boca Raton Community Hospital. I currently serve as chair of the board of directors of the American Society for Radiation Oncology, for whom I'm representing here today. Radiation oncology is an important tool in the fight against cancer, contributing over the past 25 years to steady increases in survival rates for cancer patients. In the mid-1970s, for example, the 5-year survival rate for breast cancer was 75%. For prostate cancer, it was 69%. Today, that survival rate has increased to 98% for breast cancer and 99% for prostate cancer. These are important gains. More are needed. ASTRO's highest priority is ensuring that patients receive the safest, most effective treatments. A culture of safety and quality control is woven into the fabric of our field, with many checks and balances to assure that safe and effective care is delivered to our patients. While ASTRO is alarmed and concerned by the errors described in recent press reports, we do not believe that there are widespread radiation mistakes leading to patient harm across the country. However, the reports do highlight that there is more work to do. Any error, no matter how small, must be reported, understood, and utilized as a tool to reduce the potential for future errors. Failing to report known errors is unacceptable. This moment is an opportunity to further improve our efforts to strengthen the practice of radiation oncology. We have developed a 6-point action plan we call Target Safely. Number 1, work to strengthen error reporting and to create a national database for the reporting of medical errors. Number 2, advocate for new and expanded federal initiatives to help protect patients from radiation errors. This includes supporting passage of the CARE Act that requires national standards for radiation treatment team members, supporting increased funding for the Radiological Physics Center at the MD Anderson Cancer Center and the quality assurance activities of the Advanced Technology Consortium, supporting congressional inquiry into self-referral. ASTRO is concerned that self-referral of radiation therapy services may result in shortchanging essential quality control, assurance, and patient safety protections. Number 3, work with cancer support organizations to help patients know what to ask their doctors about radiation therapy. Empowered patients who actively engage in their care are important members of our team fighting to beat cancer. Number 4, enhance the joint ASTRO-ACR Radiation Oncology Practice Accreditation Program. ASTRO recommends that all radiation oncology practices undergo accreditation. Number 5, expand educational training programs to include an intensive focus on quality assurance and safety. ASTRO strongly encourages that all radiation oncologists participate in maintenance of certification. Number 6, accelerate our ongoing health information technology interoperability effort. We want device manufacturers to implement standards that allow the transfer of treatment information from one machine to another seamlessly to reduce the chance of a medical error. ASTRO has been developing and refining many of these programs for years. In today's environment, medical technology and decision-making are increasingly complex. The above plan holds the promise of ensuring patient safety in this challenging atmosphere. Finally, I would like to illustrate the benefits of radiation by telling you the story of one of my patients from South Florida. I treated a 50-year-old woman 15 years ago who presented with bilateral breast cancer. At that time, the standard therapy was bilateral mastectomies, and the idea of a lumpectomy and radiation for both sides at the same time was considered a very advanced form of therapy. She didn't want both of her breasts removed, and we went ahead and proceeded with a lumpectomy on both sides and simultaneous radiation to both breasts. She's now alive 15 years later. I've been following her for the entire time period, and she spends time with her family, enjoys a good quality of life, and is a true success story for today. This is what keeps me hopeful and looking forward to advances in the field. My hope is that patients across the country will recognize these incidents for what they are, isolated acts, and that these reports will not dissuade patients who need radiation therapy from receiving needed treatments. We support the committee's review of these issues, and we look forward to working with you to further enhance the quality of care patients receive. Thank you for the opportunity to testify.
Thank you, Dr. Williams. Dr. Herman?
Thanks. Chairman Pallone and distinguished members, it's good afternoon. Thank you for the opportunity to testify. My name is Michael Herman, and I'm president of the American Association of Physicists in Medicine. Medical physicists are responsible for accuracy, quality, and safety of the radiation-producing technology in diagnostic imaging and radiation therapy. Although rare, medical errors can be devastating. We all wish that no one ever made a mistake. But errors still can and do occur due to a combination of unlikely events occurring sequentially or simultaneously, many times under unusual circumstances that involve complex systems. The use of medical radiation occurs in radiation oncology and in radiology practices, with millions of people receiving that radiation annually to their benefit. Each patient procedure is a complex multi-system process which combines technology and human actions. To make the process work requires coordination and participation of a team of humans: physicians, medical physicists, dosimetrists, radiation therapists, radiation technologists, all focus on the treatment of each patient. One of AEPM's primary goals is to identify and implement improvements in patient safety for the medical use of radiation. We do this through our association's activities and in cooperation with other societies and regulatory and government bodies. Some of these include the development of procedures and guidelines, producing detailed scientific, educational, and practical reports, guidance to regulatory and accrediting bodies, oversight of quality assurance and calibration processes, facilitating medical information system communication, and providing education on medical errors. AEPM believes that the position of qualified medical physicist should be recognized nationally for anyone practicing clinical medical physics. A qualified medical physicist is an individual who has completed a unique combination of graduate education, rigorous clinical training, and board certification in medical physics. All of these efforts mentioned move us toward more effective patient care and in achieving the absolute minimum error rate. However, some challenges remain. There is no consistent national recognition of qualified medical physicists. Medical physicists are licensed in only 4 states in this country and regulated at widely varying levels in the other states. The reports and guidelines that AEPM and others publish have only the force and effect of professional and scientific guidelines. There are no consensus national staffing guidelines for qualified medical physics services, nor are there consistent standards established for accrediting practices that utilize medical physics services. So what can we do? Well, much effort and progress is being made to improve quality of care and increase patient safety, but we can and we must do more. Together, medical radiation team members, professional associations, manufacturers, and government must strive for nationally consistent recognition of the qualified medical physicist and equivalent competency for all medical radiation team members by passing H.R. 3652, the Consistency, Accuracy, Responsibility, and Excellence in Medical Imaging and Radiation Therapy Act of 2009, and specifically requiring that all medical physicists involved in medical imaging and radiation therapy be included in this bill. Provide consistent, procedure-specific, consensus minimum standards for national practice guidance in radiation oncology and medical imaging that recognize qualified individuals for specific responsibilities, define communication of the team, establish minimum staffing levels, and receive timely review and amendment. Establish a rigorous minimum standard for all bodies that accredit clinical medical radiation practices based on the previously mentioned established national guidance that includes additional accredit requirements for highly specialized procedures. Link CMS reimbursement to rigorous practice accreditation for all medical imaging and radiation therapy practices. Create a national data collection system to learn from actual and potential adverse events in the medical use of radiation that allows complete and consistent reporting by medical staff, manufacturers, and others. Improve the review effectiveness of product quality in the equipment clearance process. In summary, we believe that patient safety in the use of medical radiation will be increased through consistent education and certification of medical team members whose qualifications are recognized nationally and who follow consensus practice guidelines that meet established national accrediting standards. We have been working together for years on many of these issues. We must do more, and we need some help. Together, we will continue to make the use of medical radiation safer and more effective for the people that need it. Thank you for the opportunity to speak to you today.
Thank you, Dr. Herman. Ms. Hayden.
Mr. Chairman,
It sounds like it's working. Go ahead.
that's good. Mr. Chairman and members of the committee, my name is Sandra Hayden, and I am a radiation therapist at MD Anderson Cancer Center in Houston. I also serve on the board of the American Society of Radiologic Technologists, and it is in that role that I address you today. On behalf of the ASRT's 134,000 members, thank you for the opportunity to contribute to this dialogue on the quality of radiation therapy and other medical procedures that use radiation. Radiation therapy is the cornerstone of cancer management programs worldwide. It can contain, control, and cure cancer. However, radiation therapy must be precise to be effective. Accuracy is equally important during medical imaging exams that diagnose cancer. X-ray exams, CT scans, and other imaging tests use radiation, and radiation comes with some risk. Errors, although rare, can cause devastating side effects. The ASRT believes the best way to ensure quality and safety of medical radiation procedures is to establish national educational and certification standards for technical personnel who perform them. CT scanners, gamma cameras, and linear accelerators are some of the most complex medical equipment in the world. However, this technology is ineffective in the wrong hands. That's because the quality of any medical radiation procedure is directly linked to the skill and competence of the person performing it. Individuals must have extensive education and training to perform the exam correctly. Patient safety is in the hands of these individuals, yet they remain largely unregulated. Radiographers are not licensed in 8 states. Radiation therapists, such as myself, are not regulated in 17 states, including the District of Columbia. Medical physicists have no oversights in 31 states, and no states regulates medical dosimetrists. Even in states with some type of regulation, the rules are sometimes so weak they offer patients little protection. In some states, hairdressers are better regulated than people who perform medical radiation procedures. Unqualified personnel are a danger to patients. An underexposed X-ray can't reveal a malignant tumor. An inaccurate radiation therapy treatment can't stop its spread. Even worse, when medical radiation is used improperly, it can harm the very patients it was meant to help, as you've heard from earlier. The solution is the consistency, accuracy, responsibility, and excellence in medical imaging and radiation therapy bill. The CARE bill, introduced by Representative Barrow as H.R. 3652 and pending before Congress since 2000, uses a 3-tiered approach to improving quality and safety. First, individuals who perform medical imaging and radiation therapy would be required to graduate from a specialized educational program. Second, they would be required to pass a national certification exam. And third, they would be required to maintain competency by obtaining continuing education. Only qualified personnel should be allowed to perform medical imaging and radiation therapy. The CARE bill will ensure a minimum level of education, knowledge, and skill for those who are responsible for medical radiation procedures. For patient safety, the ASRT encourages Congress to pass the CARE bill. The ASRT also calls for consistent and mandatory methods of reporting medical radiation errors. Mistakes must be reported and investigated so others may learn from them. By learning how errors occur, we can implement safeguards to prevent them. Currently, state and federal oversight of radiation errors is inconsistent. Regulatory bodies do not share information. Even worse, some states do not require that errors be documented at all. The ASRT calls for mandatory reporting of medical radiation errors and also for a consistent system of data collection and tracking. A model to consider is the FDA's MedWatch program, which takes a systemic approach. A reporting system such as MedWatch would build a knowledge based on patient safety and help reduce errors. Thanks to medical imaging and radiation therapy, millions of Americans are cancer survivors. The vast majority of medical radiation procedures are administered safely and successfully. However, any mistake is unacceptable. ASRT's recommendation will lead to safer care and will help more patients win the battle against cancer. Thank you again for inviting me to speak on this important issue.
Thank you, Ms. Hayden. Dr. Amos?
Chairman Pallone, Congressman Whitfield, and distinguished members of the subcommittee, thank you for the opportunity to speak today. I'm Dr. Stephen Amos, Professor and Chair of Radiology at the Albert Einstein College of Medicine and Montefiore Medical Center in New York. I'm a past president of the American College of Radiology, and am testifying today in my capacity as chair of ACR's Blue Ribbon Panel on Radiation Dose in Medicine. The ACR, which represents more than 36,000 radiologists, radiation oncologists, nuclear medicine physicians, and medical physicists, is committed to ensuring appropriate use of radiation in medicine. One message I must highlight today is that the proper use of radiation in medicine, whether diagnostic or therapeutic, saves lives and improves the quality of care for millions of patients each year. Please consider the following. Advances in medical imaging have rendered exploratory surgery virtually obsolete. Interventional radiologic procedures often replace more invasive surgical options, resulting in improved outcomes and reduced hospital stays. And over 1 million patients each year are cured or experience relief of pain due to treatment of their tumors with radiation therapy. Still, as has been known for the past 100 years, recent media reports remind us that the medical use of radiation is not without risk. We can and must do a better job of preventing errors. The ACR has long been involved with numerous radiation-related quality improvement initiatives. These include development of guidelines to ensure that patients get the right exam or treatment performed in the right way, creation of registries and other tools to help physicians compare their outcomes with those of their peers, and education of radiologists, fellow physicians, and the public about the risks and benefits of both diagnostic and therapeutic radiation. Of particular note, ACR strongly supports Image Gently, an educational initiative conceived by pediatric radiologists to promote safe imaging of children. To help prevent further adverse radiation-related events, ACR asks that Congress seriously consider the following recommendation, and we're not pulling any punches. A formal accreditation process must be mandatory for all diagnostic imaging services and radiation therapy practices. In this process, hospitals and freestanding facilities should be held to the same standards as patients have a right to safe and high-quality care regardless of the setting in which they receive it. Such a process should be robust and focus on considerations unique to imaging and radiation therapy, such as image quality, dose monitoring, phantom testing, equipment calibration and maintenance, and the qualifications of all involved personnel. As a corollary, since CT scans are a growing cause of radiation exposure in the United States, a CT dose registry should be required as a component of accreditation for CT practices. This would help ensure ongoing compliance with accreditation baseline. ACR has been working with industry to develop such a registry, but a congressional mandate would facilitate this process. Congress has already recognized the importance of accreditation. MQSA requires accreditation of mammography practices and has helped save tens of thousands of lives. A similar approach is seen in MEPA, it's already been described, which requires accreditation of non-hospital-based imaging practices. Both MQSA and MEPA offer important lessons on how to design an optimal accreditation process. Further, it is essential that the accrediting bodies have a proven track record in imaging and radiation therapy accreditation. The ACR is the nation's oldest and most recognized medical imaging and radiation therapy accrediting body and is the only nationwide FDA-approved accrediting body for MQSA. ACR accreditation, designed to be educational in nature, is an efficient process of both self-assessment by the practice being reviewed and independent external audit by physicians and medical physicists who are recognized experts in the specific type of practice being evaluated. We recognize there is a desirable middle ground between an accreditation process that is overly burdensome and one that lacks the substance to ensure quality and safety. We stand ready to work with members of this committee to find the right balance. Thank you again for the opportunity to testify and for holding this hearing on such an important topic.
Thank you, Doctor. Mr. Mizrak.
Good afternoon, Mr. Chairman. Thank you for the opportunity to share the radiation oncology experience at the VA New Jersey healthcare system. I will describe for you our 3-year journey that includes how we identified a problem in the quality of care for radiation oncology patients, how we responded, and how we rebuilt our program to make sure that these circumstances would not happen again. Transparency was our constant focus throughout this process and guided our decisions to ensure that we acted in the best interests of our patients. And as soon as we determined that specific patients did not receive the quality of care they deserved, we disclosed this information to 53 patients and their families, consistent with the Veterans Health Care Administration policy. Of the 53 patients, we determined that 2 patients were harmed. We informed the other 51 patients that they experienced errors that created a risk for them in the future. We are following these patients for any subsequent signs of injury resulting from the identity of any of these errors. Prior to December of 2006, the East Orange campus of the VA New Jersey healthcare system radiation oncology program was accredited by a nationally recognized external reviewing agency. Our patients were satisfied, staff members had no complaints, and all indications suggested our program was delivering quality care. In December of 2006, we first heard that 2 radiation therapy contract technicians unexpectedly were no longer reporting to work at our facility. When we inquired as to why this happened, we learned that they had raised concerns about the quality of care being provided, resulting in a conflict with the supervisory staff. We immediately initiated a review that included a series of increasingly detailed investigations of the quality of care in radiation oncology. The first review by our quality manager validated that the concern raised by the technicians were credible. In response, we made the decision to close the program down until a thorough review was complete and we were certain our program provided safe, quality care for our veterans. Patients in the need of radiation therapy have received care through fee-basis arrangements with local accredited facilities in their communities. subsequent reviews by external VHA teams of experts, and final comprehensive review by the American College of Radiology confirmed there were deficits in our programs. These included issues of staff qualifications and communication, implementation of new technology without adequate education and training, gaps in procedures for managing patients, and the lack of a robust quality assurance program. These findings became the framework for rebuilding our radiation oncology program. We needed to be sure we would deliver the highest standard of care possible and implement corrective actions to rectify all deficits identified by the ACR. During the course of the investigation, the clinical staff who had been working on our programs resigned. At the same time, the contract for radiation therapy technicians and for contract physicists expired. We then made the decision that it would not be renewed. We began improving our program by hiring new staff members, including a nationally respected, experienced, and board-certified chief of radiation oncology. We also hired properly trained and credentialed physicists, a dosimetrist, radiation therapy technicians. As radiation therapy is a complex and rapidly changing, we established a program of continuous education for all staff, and a major component of this initial and ongoing training of new technology and equipment. We next established policies and procedures to guide patients' care and instituted a comprehensive quality management program. Such a program includes meeting the standards established by the American College of Radiology. This entails identifying quality controls for every step of radiation therapy, including the dose and technique prescribed, the energy the machine delivers, the dose of radiation the patient receives, and how the patient responds to the therapy. We are continuing routine tests of our machines, simulating patient encounters, checking dose calculations, tracking patient outcomes, and instituting routine quality reviews of care, including peer review. A culture of openness is fundamental to patient safety. This means an environment where all staff members are considered an equal part of the healthcare team. To this end, we established multidisciplinary team meetings prior to, during, and after treatment to review all aspects of care. We encourage our staff members at all times to raise questions of concern about that care being provided. The most important lesson we learned through this process was that staff members must be able to communicate openly, to feel comfortable about raising issues, and to feel confident that leadership will respond to their concerns. Thank you again for the opportunity to share my experience. I am now available for questions at a later time.
Thank you, Mr. Misra. Thank you for being here, too, today. I appreciate it. Mr. Fisher.
Mr. Chairman, Congressman Whitfield, Congresswoman Castor, thank you for the opportunity to be here today. I serve as the Executive Director of the Medical Imaging and Technology Alliance, the leading association representing the manufacturers, innovators, and developers of medical imaging and radiation therapy systems. We are here today because of a tragic situation, and as an industry, we are committed to doing our part to prevent such things from occurring in the future. At the outset, it's important to note that computed tomography, CT, and radiation therapy, RT, are very different modalities used for different purposes. CT is a diagnostic tool that utilizes ionizing radiation to create detailed images of internal tissues. Radiation therapy, or RT, on the other hand, is a therapeutic tool that utilizes a focused beam of radiation to kill cancer cells. Due to their distinct purposes, the amount of radiation associated with these modalities differs by orders of magnitude. These two modalities have revolutionized healthcare delivery. The New England Journal of Medicine recently called medical imaging one of the top healthcare innovations ever. Likewise, radiation therapy offers highly personalized, non-invasive, and cost-effective care for up to 60% of all diagnosed cancer patients in the U.S. MIDA has a long history of working with its members, physicians, physicists, technologists, regulatory bodies, and other stakeholders to track and reduce medical radiation. Our members continue to introduce new products and system innovations that reduce radiation dose for many procedures while continually improving image quality. New technologies like weight and age-based protocols, automatic exposure control, software improvements, and improved interfaces with operators all enable dose reduction. MIDA is also working collaboratively with other stakeholders on issues related to medical radiation and the use of radiation-emitting equipment. For example, in November of last year, MIDA convened a meeting including physicians, physicists, industry, and Food and Drug Administration officials to discuss ways to prevent future medical errors that involve ionizing radiation. MIDA is also co-sponsoring an upcoming CT dose summit and is also considering a radiation therapy summit to work with the AAPM on a radiation therapy summit. to further the education of providers, physicists, and others on the new technologies, dose reduction technologies in particular, our companies manufacture. As part of the Access to Medical Imaging Coalition, MIDA helped to develop appropriateness criteria for advanced medical imaging included in the Medicare Improvements for Patients and Providers Act, or MIPA. More recently, MIDA announced its support for the President's proposal in the fiscal year 2011 budget to develop a national dose registry. We also welcomed the FDA's recent actions regarding radiation dose and support many of the policies proposed in their initiative to reduce unnecessary radiation exposure for medical imaging. MIDA intends to participate fully with FDA as they work to implement dose reduction policies. And MIDA also has recently made two announcements in the area of radiation dose that may be of interest to this committee. Yesterday, MIDA announced a new dose check initiative in which CT manufacturers committed to do three things. First, a new radiation dose alert feature, which is designed to provide a clear indication that the settings for the CT exam will result in a dose higher than a predetermined reference dose for routine scans. Second, manufacturers are committed to including a dose warning feature to prevent CT scanning at higher, potentially dangerous radiation levels. This feature is designed to prevent hazardous levels of radiation that could lead to injuries. This feature can also be configured by hospitals or imaging facilities to prevent scans at these higher radiation levels. Third, manufacturers will also standardize dose reporting to help better understand dose levels and facilitate the development of the National Dose Registry proposed by the President. Several weeks ago, MIDA also announced a dose reduction plan, including the development of radiation dose reference levels to assist clinicians to understand the relative amount of radiation associated with the scan, expansion of the appropriateness criteria mentioned earlier to ensure that patients receive the right test at the right time, the development of training standards for hospitals and freestanding imaging facilities that purchase imaging equipment that involves the use of radiation and radiation therapy equipment, efforts to develop safety checklists to reduce medical errors and to incorporate those new standards into our training offerings, efforts to ensure standardized reporting across stakeholders in a manner that is transparent for patients, their families, and physicians, an examination of whether the MIPA accreditation policy should be expanded to include additional facilities where radiation therapy medical devices are in use, and the establishment of minimum standards for radiologic technologists who perform diagnostic medical imaging exams and deliver radiation therapy treatments. In each of these cases, MIDA and our member companies stand ready to work with professional organizations, regulatory bodies, individual clinicians, and other stakeholders on these features. Lastly, MIDA continues to work with all of our members whose companies manufacture products that emit ionizing radiation to develop new ways to reduce dose and reduce medical errors. And I am hopeful we will continue to make strides in this area. As we look to the future of healthcare in this country, we cannot see our way to better outcomes and lower costs without the lens that medical imaging provides. The medical technologies MIDA member companies research, develop, and manufacture are the future of delivering better health outcomes at lower costs. Thank you for this opportunity today. As the legislation process proceeds, MIDA looks forward to continuing to work with Congress and the administration to ensure appropriate use of and access to medical imaging and radiation therapy.
Thank you, Mr. Fisher. Mr. Donahue.
Thank you. Chairman Pallone, Congressman Whitfield, my name is John Donahue, and I am grateful to be here to discuss the issues surrounding ionizing radiation in medicine. I want to begin by expressing my profound admiration for the courage of the Parks family. I am here as the Vice Chairman of Medicalis. Medicalis is a leading innovator of technology and clinical solutions focused on improving access to high-quality, safe, clinically appropriate advanced diagnostic imaging. We're a company founded by the radiologist and information technologist at the Brigham and Women's Hospital in Boston. We provide physicians at the point of ordering with web-based radiation safety and clinical appropriateness decision support. By way of background, I have been in the international healthcare industry for over 25 years, in the pharmaceutical, vaccine, and the radiology industry. In the late 1990s, I co-founded and acted as president and CEO of one of the nation's first and the largest radiology benefit management companies. I have had the opportunity to interact extensively with CMS, MedPAC, the GAO, congressional offices, and many of the stakeholders in this area on an array of imaging issues. Diagnostic imaging is rife with many health policy and federal legislative opportunities. I am hopeful that after today's hearing, we will all agree that radiation safety in imaging is a measurable and very serious issue, but there are specific steps that we can take to mitigate the risk. Radiation safety has been very much in discussion since 1895, when a new kind of light, the X-ray, was discovered. In July of 2005, the National Academy of Sciences issued a seminal study that examined health risks from exposure to low-level ionizing radiation. Today, this study is commonly referred to as the BEER-7 report, or the Biological Effect of Ionizing Radiation report. The watershed conclusion was that any level of ionizing radiation can induce a carcinogenic effect. The report showed that a single CT of the abdomen emitting 10 millisieverts of ionizing radiation increases the risk of induced cancer to 1 in 1,000 times. Further, and importantly, cumulative dosage totaling 100 millisieverts can ratchet up this carcinogenic risk to 1 in 100 times. It is also important to note that although radiosensitivity values vary dramatically by body tissue, as well as by gender and by age, studies have shown that there are meaningful dose estimates that can be measured. For example, the Cleveland Clinic submits that an abdominal CT emits roughly 10 millisieverts of radiation, a cardiac PET 15, a CT urographic study 44, while a plain chest X-ray emits less than 0.1 millisieverts. In 2006, I helped lead a radiation safety dosage initiative and awareness program. The results were startling, and they were highlighted extensively in the Wall Street Journal. Firstly, some individuals received radiation exposure more than 1,000% higher than recommended guidelines. And secondly, one patient received 341 CT scans over an 18-month period, bringing the radiation exposure level to almost 1,000 millisieverts. In 2007, I presented yet another radiation safety initiative focused on the Medicare population. In this particular study, over a 12-month period, almost 20% of the medical population, of the Medicare population, received radiation exposure that exceeded the BEER-7 radiation recommended levels. Diagnostic imaging is an extraordinary clinical tool. We want to encourage and expand the appropriate and the safe use of diagnostic imaging, but the evidence appears to be incontrovertible that patients are all too often exposed to unnecessary levels of ionizing radiation. I believe the solution is to do four things. Firstly, to ensure that every advanced imaging study is clinically proven by evidence and that it is not redundant. Secondly, to measure and report on individual cumulative millisievert dosage and present this ionizing history to physicians at the point of ordering. Thirdly, I believe we should require recommendations of viable clinical alternatives to enhanced radiation risk when they exist. For example, could an ultrasound, a lab test, or some blood work be sufficient for an initial diagnosis? Finally, the fourth is I believe that once these tests pass these three criteria, that they should be performed by in facilities by physicians and by rad techs who are accredited and trained, and that the equipment is assured to be set at the correct specifications. My company, Medicalis, is able to deliver clinical appropriateness and radiation safety today. We continuously survey and present available patient information to physicians at the point of ordering, including an individual-specific radiation history dosage. We also evaluate the clinical appropriateness of the test and present alternative recommendations if radiation safety sparks a concern. In 2010, we have no excuse but to leverage available clinical evidence, innovative technology, and regulatory policy to assure that all Americans receive clinically appropriate and safe advanced diagnostic imaging. I would respectfully suggest that Congress encourage CMS to encourage a web-based, or to include a web-based clinical decision support and radiology safety program in the upcoming radiology pilots. In addition, and finally, I want to commend the Food and Drug Administration's unveiling of its recent radiology initiative. Specifically, the two underlying principles of appropriate justification of a radiation procedure and the optimization of the radiation dosage. These two issues address many of the concerns that I've raised in this testimony, And we look forward to working with the FDA and other imaging stakeholders as this effort moves forward. I want to thank the chairman. I want to thank the entire committee for your focus on this issue, and I'd be pleased to answer any questions.
Thank you, Mr. Donahue. Thank all of you. We'll take some questions now. Let me start out by saying that that Dr. Michael Hagan, I guess, is here to accompany Mr. Mizrak. That's you. Raise your hand. Okay. And that would be if we have any questions about the VA in general, I understand. And then I also would ask unanimous consent to enter into the record a statement by our Chairman Emeritus, John Dingell, without objection, so ordered. I'm going to start the questioning, and I wanted to start with Ken Mizrak, if I could. Again, the reason why your testimony is so valuable, in my opinion, is because you, at the VA hospital in New Jersey, went through a situation where there were problems. You closed the facility. You came back and corrected them. And so I think that example is sort of a good one. And in part, what I'm asking is whether these changes that you've made, could be utilized at other facilities. I mean, that's really what I'm trying to get down to. But let me just say, Mr. Mizra, you mentioned in your testimony that you will require continuous education for all staff, specifically with respect to the technology and equipment. Can you elaborate on this in more detail and explain how you think this is going to work in practice, and I guess also whether it would be useful for other hospitals?
Well, I think there needs to be a constant, continuous education on any new piece of equipment in a medical center, whether it's in radiation oncology or radiology department or audiology and speech. There are programs available nationwide, constantly being offered. We need to make sure that our specialists are certified and trained before they have any opportunity to use the equipment. Recently, as we're getting ready to open our program, we brought in the manufacturers to work with our staff to observe simulations, and that was part of the process. And before we get the green light to open, we need to make sure that everyone is equipped. I want to know that my airline pilot is ready to fly that new piece of equipment before I get on that plane, and there should be no difference in being treated in a medical center.
Now, you mentioned conducting routine tests of the machines to make sure that the therapy you are providing is correct and safe. One of the recent articles in the New York Times highlighted a hospital that has been over-radiating patients for the past 5 years, and their regular system checks did not catch the error. So can you just elaborate a little more on this aspect of the quality assurance plan and how these types of tests work, and, again, how they would be, help prevent situations in other hospitals?
I would really like to defer that to Dr. Hagan, who really has the expertise in the...
All right, he'll have to come up, I guess, and take your place there. I don't know, or use one of the mics.
What's going on with that? I think this is close enough to the mic, if you can hear. Mr. Chairman, after East Orange, shortly after East Orange, the VA nationally required ACR accreditation for all radiation oncology facilities within the VA. Nationally, fewer than 20% of radiation oncology practices are ACR accredited. This requirement for accreditation comes with some teeth. In the last year, under signature by the Principal Deputy Undersecretary, any finding by a surveyor at a VA site now must be corrected, and the authority for that correction goes up to the network director, and the network director is required to report through my program office to the undersecretary that each item has been corrected. So that puts the quality control loop. To answer your specific question, though, about the physics oversight for radiation oncology, it's a little bit different. Although when ACR evaluates, they evaluate both with medical physics and the process with a radiation oncologist. Most of our centers put patients on NCI-sponsored trials, and so they fall under quality assurance program for the Radiologic Physics Center. You've heard that mentioned by a couple of panelists today. That's a federally funded undergrad center out of MD Anderson. Prior to initiating treatment again in East Orange, RPC paid a visit and went through their very extensive evaluation of the LINACs at that facility. And so they have been surveyed with almost 36 hours of continuous operation with a physicist going through each of the planned operations. And actually, it's a result of that initial evaluation that we're continuing to hold on treatment of the first patient until all of the issues that were found by the RPC have been resolved.
I guess going back to my initial statement, to what extent is what you're doing now something that you would see that we should apply nationwide or to other hospitals not in the VA system?
It's an excellent question. And RPC is mandated to support with on-site evaluations all centers place patients on NCI-sponsored trials. To be able to expand that kind of service nationwide would require an order of magnitude increase in the size of a facility like RPC. Actually, it would jeopardize their ability to perform their mandate, which is to support clinical trials. But to use RPC as a model and then fund a similar organization that can do that level of observation on a routine basis in each center should be mandatory.
Okay. Thank you very much. I don't even know what my time is here, so I have another 2 minutes. I'm not sure that's accurate. I think I may have given myself more time, but in any case, let's see. I'm going to ask this of Dr. Herman, I guess, if I can shorten this with the time. In one of the New York Times articles, in order to qualify for a clinical trial on radiation therapy, the institution has to submit to enhanced testing to make sure that they were delivering therapy properly. And I guess a lot of the institutions failed those tests, according to the New York Times. But in a report by your association, Dr. Herman, you also said this was a sobering statistic, and I agree, and that the tests are quite rigorous, but still when our nation's top institutions apply to a clinical trial and often fail, we should wonder what's happening. So I wanted to ask you, do you think that this is a sign of a larger problem? And I don't know, I just wanted someone to respond to that about, if I guess it could be you, Dr. Herman, sure.
It's certainly indication that that it's difficult to carry out IMRT treatments. One of the things, the sentence that follows the part about the sobering statistic in that same report suggests that there's a larger consideration with the commissioning portion of the systems that comes before the clinical use. So the details of the algorithm and some of the other things that can create additional variations. And some of the results, some of the cases that didn't pass in the first, the RPC phantoms, were also due to not using the entire team to do the treatments. So I think one thing that would be helpful is to have the phantom go through the entire identical process to what a patient goes through, as opposed to sometimes having physicists try to do the whole thing, because you're not taking advantage of the entire team component.
Okay. And Ms. Hayden, you know, you talked about all these variations in terms of education, standards, accreditation from one state to the next. And you obviously mentioned the CARE bill, that you'd like to see that promulgated. It seems to me, frankly, that, you know, what you suggested is probably, you know, it may be one of the most important things to do, because the technicians are such an important part of this. So I don't know if you wanted to comment any more about, you know, the importance of national standards, but I have to say that it was really disturbing to me to read that there was so much variation from state to state. And I don't know if you wanted to add anything more about it, but I just thought that was really sobering more than anything else.
Of course, Chairman Pallone, I appreciate this opportunity to speak again on behalf of the ASRT, as well as on behalf of the radiologic technologists that administer radiation therapy and do the radiologic technology medical imaging exams. It is very sobering. The radiation therapist in my case, which is what I am, we're the last line of defense for the patients. We are the safety net for the patients. We are the ones that's turning on that machine. We work in collaboration and we follow the prescription from the physician. We work hand in hand with physics. I feel like I want to hold hands at the table. But certainly the care bill itself is just common sense to have educationally prepared, clinically competent practitioners, radiologic technologists is what we like to be referred as, to actually deliver this care for patients. Patients should be the #1 focus of this, and I'm awfully happy that you have.
Let me just
ASRT
ask this, and this will be my last question. If we were to implement, let's say we were to pass the care bill, I guess you'd have to make it moving forward. You couldn't make it retroactive, presumably. How long would it take before you'd be able to have enough people to perform these tasks that would meet the standards of the care bill? I mean, are we in a position that we'd have to say 2, 3, 4 years from now before we could actually have enough people that would meet the standards?
Yes, Chair.
Sure.
We actually have time frames. There will not be a shortage in regards to the people that will actually be performing the examinations with the care bill or the passage of the care bill. As a total opposite, it also will help save money in regards to not having repeated images and things of that nature. And in addition to that, there's effective dates to the care bill. And so you would definitely follow that, and I have it in my hand here for you. But we just want to be sure, the ASRT, that the people providing care to patients that deliver radiation therapy and medical imaging have minimal education requirements and are competent.
It makes perfect sense to me. Mr. Whitfield.
Thank you. Ms. Hayden, I'd like to just expand a little bit on Chairman Pallone's questioning. You indicated you felt like you should be holding hands with Dr. Herman there, and
we do all the time. I work at night with physics all the time.
But to help me have a little better understanding of this, you're at MD Anderson, correct?
Yes, sir.
Okay. So the team that's involved in the treatment or the diagnostic work would be you, the medical physicist, and the radiation oncologist. Would that basically be the team for treatment?
We also have medical dosimetrists as well, and radiation therapists.
Okay. Mm-hmm. And now, what is your educational background? What is required to be a radiation therapist? You have to have an undergraduate degree, and then...
Well, you asked my personal credentials is I have a baccalaureate, a science degree in radiation therapy technology from Michigan, Wayne State University. But there is different qualifications for radiation therapists now, as you heard, within 17 states. I received registry, and my certification exam I passed through the American Registry of Radiologic Technologists, which then makes me able to then be a qualified radiation therapy professional.
Now, in some states, could you be a radiation therapist with just an undergraduate degree?
Yes, you can be a radiation therapist with any sort of qualification in the states that don't regulate it. I worked in Michigan and practiced there for over 10 years, sir, and I worked side by people because Michigan is an unregulated state for radiation therapy that did not have credentials. And I must say it was very painful, and I made sure that our patients were cared for, but it is very, it's not a good practice to be able to have practitioners that have all sorts of varying credentials or non-credentials delivering radiation therapy care.
So, Dr. Williams, are you and Dr. Herman very much concerned about that as well?
Yes, sir.
Are there 17 states that does not require licensure? Is that what you said?
I'm not sure of the exact number, sir, but there are a number of states that don't require any licensure whatsoever.
So then the hospital or facility that hires them, they just have the free rein to hire whoever they want to. Is that correct?
Yes, Congressman.
And then hopefully they have a training program of some kind and go from there. Okay. We have some work to do. Yeah, yeah. Dr. Amos, in your testimony, you indicated that MIPA's accreditation mandate should apply to all facilities, including hospitals. And I was wondering what other settings besides hospitals are not covered by the MIPA requirement?
It's my understanding that basically there's hospital-based and then there are independent centers, and that MIPA only does apply to the freestanding non-hospital-based centers. And we feel if there's going to be mandatory accreditation, it should involve all centers so that we all have the same standard of care. Patients can.
So freestanding has to meet the requirements, and hospitals are not required to do so.
That's correct. My understanding under the MIPA regulations.
Okay. Now, Mr. Fisher, you and Mr. Donahue are involved in a different way in this area we're talking about. You represent some of the medical device manufacturers,
yes.
And you also, Dr. Donahue, Mr. Donahue?
No, I represent a medical management company that focuses on providing radiation safety to physicians when they order advanced imaging.
So you're a contract manager then for facilities?
Yeah, we're a healthcare information technology and a clinical company, and we work with large hospitals like the Brigham and Women's System, work with General Electric, and increasingly are working with health insurers throughout the country who are, again, very focused on clinical appropriateness and radiation safety.
Yeah. I remember in your testimony you talked a little bit, I believe, about individual radiation history.
That's correct.
And does your company actually do that now?
Yes, sir, we do. It's there are metrics available, readily available, that can create a very accurate measure of radiation dosage when it's applied, and it's critically important to track this over a long period of time to assure that cumulative dosage doesn't put a patient into carcinogenic risk. So we as a company perform that service. We track dosage, we measure it, and we embed that information into the electronic medical record of the patient, so it is there for the life of the patient, irregardless of the insurer or if they move into a Medicare environment.
Is the dosage that a patient receives, is it required that that be in the medical record? Dr. William or Dr. Herman?
No, sir, not at this time.
It's not. So if a patient comes to a facility that you manage and you don't know anything about what they've been exposed to, so you're talking about only while they're a patient at the area you're managing?
Yes, sir, but what we do for health insurers, for example, is this is such a concerning issue. We do a forensic analysis based on their claims data and based on any available clinical data to try to create a history of ionizing radiation. So, for example, we can delve into a multi-million data set of claims data and put together how many CTs, what body part, and what the cumulative exposure would be for a patient. So we feel so strongly enough about the safety issue that it's worth the effort to go back and to do this, and then on an ongoing basis, every new imaging procedure gets measured and tracked. And importantly, if there is a situation where a patient becomes at enhanced risk, that next incremental study could present a carcinogenic risk, the physician is immediately alerted electronically and provided with alternative action to consider.
And how many facilities do you all manage?
We are a relatively young company. Our largest facility is the Brigham and Women's Hospital System in Boston, which is, we manage inpatient and outpatient very extensively. Mm-hmm. But this approach is gaining a lot of attention and traction throughout the country.
Right. Ms. Hayden, is it required at MD Anderson that on the medical record the dosage of radiation given to a patient be on the medical record?
Sir, I respectfully, in regards to diagnostic imaging, which is not a department that I work in, I can get back that answer to you in regards to my own facility. Yeah. In regards to radiation therapy, yes, the dosage is recorded for radiation therapy.
Oh, okay, for radiation therapy.
Not for, yeah.
Okay. Okay. Well, Mr. Chairman, I see I started with 5 minutes. I now have 10 minutes and 50 seconds to go. So,
yeah, I think that our clocks are a little off.
Yeah.
I have
but
to be honest.
I would like to ask unanimous consent, however, to enter into the record a letter from the Society of Interventional Radiologists, simply on their views on this issue, and also from the radiopharmaceuticals views on this issue.
Without objection, so ordered.
And thank you all very much for your time and your testimony today. We really appreciate it.
Thank you, Mr. Whitfield. Did you want to add something, Mr. Donahue? No. Let me say this. I mean, this has been incredibly useful and thought-provoking. As I mentioned to the previous panel, we will undoubtedly get back to you with additional written questions, usually about 10 days from now, and then we'll ask you to get back. But I have to be honest, and this is in no way meant to be offensive. As much as valuable as your responses were, in many ways, I felt that we had that we ended up with more questions as a result of your responses. In other words, I think it's very likely that we're going to have an additional hearing on this subject, because so many questions came up today that that I didn't even think about initially. And if we are going to develop legislation, well, I shouldn't say develop, we already have the CARE legislation. I think before we move on that or have a hearing, legislative hearing, or draft something else, we probably will need to have an additional hearing, because I just had so many questions that came out of this today. But really, you were extremely helpful in us trying to get to the bottom of some of the problems out there. And not to suggest that, again, we're not suggesting that we don't want people to proceed with CAT scans or other diagnostic tools or other forms of radiation, because we know how important that is. But there are just a lot of questions, I think, that need to be answered. So thank you very much, and we'll conclude the hearing today, but I can't emphasize enough how valuable this was. And without objection, the hearing is concluded.